All right, let's resume and gather for our next presenter. Cresta Jones received her medical degree from the Medical College of Wisconsin. Go Badgers, go Packers, go anybody from Wisconsin. She completed her residency in OBGYN and her fellowship in maternal fetal medicine at the University of Vermont College of Medicine. And her clinical focus is treatment of opioid use disorders in pregnancy and responsible opioid prescribing. And I know we could go on and on about her bio. She does so many, many wonderful things. But I'll let her tell you more about that. But please give Dr. Jones a warm welcome.
Thanks, Becky. And during this time, the same as with Rebecca, if you guys have any questions, please raise your hand and interrupt. I've kind of changed this talk a little bit because I want our new residents, welcome to all of you, to kind of have a basic understanding of this because I don't really know what kind of experience you come in with. But we're also starting a new collaboration here with some of the community health centers where we will be starting buprenorphine medication-assisted treatment in the hospital on the antepartum service. So I really wanted to take some time to go over the specifics of that because I don't know that anyone ever talks you through all of that. So I have no financial disclosures, and I think the other thing that's very important to remember is that opioid use disorder treatment in pregnancy is not FDA approved, will probably never be FDA approved, but it is still the standard of care to treat with the medications that we'll go over. So I'll talk very briefly about the implications and stop me if there's any specific details that you have questions about. A lot of you have heard this lecture from me before. And what I really wanted to focus on is the practical management. So when you're on the antepartum service, when you're on labor and delivery, how do you manage patients who are struggling with opioid use disorder? How do you score them for withdrawal? What is the emergency treatment initiation? What can you do from a medical legal perspective with regards to starting treatment? And then how do you manage women who are either in treatment or not, who come in for labor and delivery? So this is just looking at the trends in the state of Minnesota, and this is women and men who present for treatment admissions. So this is inpatient admissions in Minnesota, and looking at the specific substance that's identified as this primary substance of use. And you can see that the dark, very darkest blue or black line is opioids, and that has gone up dramatically in the last 8 to 10 years. Something that's really scary, but way outside the scope of this lecture today, is the spike in methamphetamine, which we saw in 2003, 2004, and then a dramatic decrease with limitations in access and with incarceration, has started to climb, and it's very possible that methamphetamine misuse and use disorder will surpass opioids in Minnesota in the years to come. These are opioid-related deaths in Minnesota since 2005, and you can see by and large that's been increasing pretty significantly over the past 10 to 12 years. And this is women. So this is women who are admitted to treatment, inpatient treatment in the state of Minnesota. So the green is non-pregnant, and the blue is pregnant women who are being admitted with identified opioid use disorders. And this is just a plot that I did looking at the trend for pregnant women. So you can see that the use in pregnancy, or at least women who are identified as using in pregnancy, are increasing as well. We see this also when we look at neonatal abstinence, the most common complication of substance use or opioid use disorder in pregnancy, that babies who are affected by neonatal abstinence syndrome are also increasing. So when you have a woman who's pregnant in your care who suffers from opioid use disorder, we have very conflicting interests because my primary patient is the mom, and the one I'm going to take care of for the rest of her life is the mom. But I also want to minimize any complications to her infant. And so you're kind of balancing those, and there are some things that are going to maximize long-term health for the mom that are not going to maximize or limit the amount of infant complications. And the social context, both here in the state of Minnesota and in this country as a nation, does not promote disclosure. There is significant stigma, both in the language that's used by our government and by the conversations we have with regards to substance use in pregnancy. And there are many states, and this is one of them, where criminalization of substance use disorder is undertaken in pregnancy. And so this is a medical disorder. I won't talk a lot about this at length, but to me, this is just like diabetes. This is a medical disorder that needs to be appropriately managed. And if you don't treat the mom with the best evidence-based care, the baby is not going to have the best outcomes. So I'd encourage all of you, especially our new residents, to take a look at these 3 resources, all of which are easy to access online. So ACOG has published 2 guidelines, one on opioid use disorder in pregnancy specifically for the mom, one that is a combination with the American Academy of Pediatrics and other organizations to talk about use in pregnancy and also management of the infant. And on the right is the new clinical guidance for treating pregnant and parenting women. So this is moving past just the mom as a vessel to keep this baby safe, but hey, how do we encourage this mom that her chance to parent is important as well, and we're in this with her for the long haul. This is a really great resource. It gives clinical situations, and it uses a lot of expert opinion that you don't often get in things like executive summaries or committee opinions. And it's also free online from the SAMHSA, which is a part of the federal government. So there are complications, and this is more for our new residents. There are both maternal and fetal or neonatal complications from both treated opioid use disorder and women who have ongoing substance abuse. So women have a higher rate of infections. Those can also pose risks for the baby, injury and overdose, and obviously death. Babies of moms who have untreated opioid use disorder have poor fetal growth and fetal growth restriction. The preterm birth rate in Minnesota is substantially increased. So 26% of women with opioid use disorder experience a preterm birth versus 11% of women sort of in the general population. And we talked a little bit about the infectious exposure. I won't talk a lot about neonatal abstinence. That's certainly something I can go into individually with you in more detail or for another talk. But the most important is up to 70% of babies will withdraw from opioids if they are chronically exposed in utero. And they can be in the hospital for days to weeks to months. And we'll talk a little bit about the important stuff to talk to mom later in the slide. We treat these women because we don't want them to go through withdrawal symptoms in pregnancy. We want to prevent the complications of non-medical opioid use, not to mention most of the heroin in Minnesota, up to 70%, is now tainted with fentanyl. So there's a very high risk of overdose. There is significant improved adherence with prenatal care and also their addiction treatment if they are on medication-assisted therapy. And the risk of obstetric complications is substantially reduced if they are in treatment. So what does it mean they're in treatment? So primarily, the 2 things that will improve outcome in pregnancy is putting a mom on methadone maintenance or putting a mom on buprenorphine. So methadone is a elixir. Typically, patients go to the clinic every day. They are special federally regulated clinics that they have to show up for. As they demonstrate compliance, women can be spaced out to go less frequently, but by and large, it's an everyday thing. Those are often very good for women with very chaotic lifestyles, just kind of getting them back into this daily responsibility. Buprenorphine is a medication that I prescribe. It's something that any of you can prescribe once you have your DEA waiver. And when I say any of you, that currently applies only to physicians and nurse practitioners. They expanded the providers this past year and somehow forgot to include certified nurse midwives. So that's a bill that's currently in the federal legislators, and we can talk a little bit about that offline, about how to advocate for expanding their ability to prescribe as well. Detoxification is basically what it sounds like. You get a woman off of opioids, and she maintains abstinence from all opioids during the pregnancy. There's about a 90 to 95% relapse rate on this. It's just simply very difficult to do. It's a medical complication of a medical disorder. You need to be on treatment. So this is kind of what's important for all of you. And I know that often as second years, you'll start to manage some of our patients. And so what is it important for you to do if a woman comes into your clinic and says, you know what, I started with some pain pills, I had a back injury, I didn't realize how great they made me feel, and now I'm using heroin that I'm getting illicitly, and I really want help, I'm 20 weeks pregnant. So what do you need to know to figure out what's the best treatment for her? How do you screen and score patients for withdrawal? How do you start buprenorphine? How do you start methadone? And how does this influence labor and delivery? So this is kind of a busy slide, and all of these will be made accessible for you. But when you go in to talk to a patient who's struggled with any kind of substance use, whether it's opioids, methamphetamine, what have you, cocaine, you really want to get a history of what's going on in their life to help make the best choices, and also know what you need to be aware of for triggers for relapse. So you need to know, how long have they been using? What was the first time they used? What history do they have? Have they ever gone without opioids before? What happens? What are the symptoms that they have when they go through withdrawal? Have they ever injected? If they have they ever shared needles? What's the longest they've ever been in treatment before? What were the keys that they found that kept them in treatment? And what are the triggers that made them relapse? I think those are really important questions that we often don't ask patients. And also what other substances we use. Because maybe a patient comes in because, yes, she's struggling with opioid use disorder withdrawal. But I've had numerous patients where I say, what is your drug of choice? If you could pick anything, what would you choose? And they say, I take opioids because I don't want to have withdrawal, but I would prefer to use methamphetamine. And for those patients, it's a very different reality for their treatment than women who are exclusively using opioids. So really trying to find out what is their drug of choice, and what can you do to keep them in treatment. You also want to ask, have you ever traded drugs for sex? Do you have any legal issues? Do you have any current legal issues? Have you ever had problems in the past? Have you had to spend any time in incarceration related to struggling with your substance use? Do you have any other children? And if you do, are they in your custody? Are they with family? Are they in a safe place? Are you in a safe place? Ask them about physical and sexual abuse. So many of these women have had significant trauma, and Rebecca talked about that today. But if you have the opportunity to look into trauma-informed care, if you haven't before, instead of saying, why won't this woman quit using? What's wrong with her? What happened to her that she has gotten to this point in her life? And when you look at it in that perspective, when you say it in that way for so many things in life, it really allows you to generate more empathy towards the women in their journeys. So asking about a family history, not just of substance use, but about addictive behaviors in general. There are people who have a strong family history of gambling disorder, and we are more and more finding a genetic predisposition to addictive behaviors and use disorders in general. I mean, they even now have gaming use disorder, which has been diagnosed, and you'll see people who are playing games on their, Xbox for 20 hours a day. So it is something about the way that their brain finds happiness and satisfaction. And so getting that history is also very important. A lot of these women will normalize use. Yeah, I took pain pills with my mom or with my stepdad. So it's just a very different experience than you might think about. Knowing who's going to help them in their journey. So is she living with active users? Does she have any friends that aren't active users? Does she have people that she can be with to stay away from the temptation of illicit use? And who knows about her disorder? If women say nobody knows I'm here, they're at a much higher risk of relapse than women who say my family knows about my journey, I have sober friends who are going to help support me. So those are the questions that you're going to want to go through whenever you're interviewing a patient. And I just say, I need to get all of this information because I want to make the right decision for the right treatment to keep you healthy. So treatment in pregnancy is not an emergency. It's only a priority. And I say this because we had a patient who was supposed to come in today. Did she ever show up? No. Oh, bummer. So we have in our new current program, when women are identified as high risk for starting on treatment as an outpatient, they will come in and the MFM antepartum service will initiate buprenorphine or methadone therapy for them, whichever is appropriate and whichever treatment program we can get them into. We have a partnership with the Kook Clinic, if any of you are familiar with that. It's a community health center partnership with the University of Minnesota that has 3 prescribers who treat women with buprenorphine. But they're going to come in and be what's called induced, so we call it an induction onto the medication in the hospital if they're at a high risk. Either it's not safe for them to do as an outpatient, their social situation is too chaotic, or they're in the 3rd trimester of pregnancy because there is a higher risk of preterm labor during the process. So these women are going to come in, as of right now, Monday through Thursday. So this woman called at 5:15 in the afternoon on Friday, showed up at the clinic and said, hey, I'm ready to start my treatment. And I'd like to be able to accommodate every patient 24/7, but I also understand that we have to keep our providers healthy, and burnout is a significant issue with substance use disorders. So for these women, we want to get them in for care, but we also have to understand that we have to keep ourselves healthy. And before we start treatment, we have to confirm that someone's actually pregnant. And we have to confirm that they actually have opioid dependence, because both of these things, I've been burned in these situations before. So this seems kind of elementary, but you know, if a woman comes in as like, I'm 30 weeks pregnant and I say, okay, I have to see symptoms of withdrawal, I have to get fetal heart tones or at least an ultrasound, because I need to confirm that before I start your treatment. So this is just kind of the pros and cons of the two medications that we primarily use in pregnancy. And the things that are important when we're talking through that history that I already gave you is which patients will do better on which medications. So in general for methadone, it's women who really need that structure in their life. If they are polysubstance users, so nothing has been found to be effective, more or less effective for polysubstance users that have methamphetamine as another primary disorder. But for women that also struggle with cocaine use disorder, methadone works much better. There's a higher overdose risk with methadone, and their babies have longer treatment in general. But there is a group of women, if they were abusing buprenorphine, that methadone might be a better first start for them if they failed buprenorphine outpatient therapy. And this is really one of those things that with each case, you kind of talk them through with me and we say, okay, which medication do you think they're better for? And you kind of tell me what you think, and then we talk through whether that is really the best choice. And ultimately, it depends on what the patient will accept as well. With buprenorphine, patients have to be in withdrawal to start it. It is a partial agonist antagonist, and it has very significant binding to the receptor, so it has a very high affinity. So if someone comes in and they've just used heroin and they take buprenorphine, it will bump the heroin off some of those receptors, and the partial antagonist effect will cause a precipitated withdrawal, so a severe withdrawal syndrome that you can't overcome with anything else, because you just have to wait for that buprenorphine to wear off. So women have to come in and be in clear withdrawal, or taking the buprenorphine is just going to make them much sicker. There's an increased diversion because you can take the medication home with you. There's lower retention because the euphoria that women get with the pure agonist effect of methadone is not there with the partial antagonist effect of buprenorphine. So a lot of women will say, I just don't feel well with the buprenorphine. And I would argue that they feel normal, but their normal is a very uncomfortable place to be, whether that's from dual diagnosis, mental health issues, or just a general sense of unease with everything that's going on in their life. And there's less information on long-term outcomes for children with buprenorphine. We now have about 5 to 6 years worth of data, but the long-term we just don't know yet. We have that for methadone. Methadone's been around since the 70s. So withdrawal in pregnancy, ACOG really tells us if women don't accept treatment or they can't get access to treatment, that we will try withdrawal as an option, but only with significant counseling on the risk of relapse. We used to not want women to go through withdrawal because the fear was that their baby would die, that there was a higher risk of stillbirth, that there was a higher risk of miscarriage. And in fact, that's absolutely not the case. The reason we don't want women to go through withdrawal and abstinence is because there's a high risk of relapse. And because we care about the mom just as much as the baby, we need to balance both of those things. There is a difference between withdrawal and medically assisted withdrawal. So withdrawal is just cold turkey. Medically assisted withdrawal, or MAW, you'll hear a lot of literature on that. So you're basically often admitting a patient, starting them on a low dose of methadone or buprenorphine and weaning them off that very carefully, or treating them with withdrawal medications to treat their symptoms. So I want to talk a lot about the 72-hour rule, because anyone who's worked with me has probably heard me mention this, and this is what allows all of you, even if you're not addictionologists, even if you don't have a treatment program, to treat somebody for 72 hours. So this is a federal regulation. It's Title 21 CFR Part 1306.07b. You don't need to know that, but what you need to know is that you can administer, if you have a DEA license, for anyone who is licensed to prescribe opioids. So although you can't prescribe buprenorphine as a CNM, you can participate in the 72-hour rule. So you can administer but not prescribe. So the difference is administer is giving them the medication, prescribe is giving them a prescription to get the medication. So you can administer a patient a narcotic drug for the purpose of relieving acute withdrawal symptoms while arranging for the patient's referral to treatment. This doesn't have to be buprenorphine. It doesn't have to be methadone. It can be any opioid that will stave off withdrawal long enough to get them into a treatment program. And the reason behind this rule is that the best time to engage anyone in treatment, this isn't just for pregnancy, is when they come to you and say, I need help. And so this allows us, if someone presents in preterm labor, oh, by the way, I'm withdrawing from heroin, let me stabilize you and let's get you into a treatment program. Unfortunately, this really was designed for people who want to get into treatment, so we don't have really good guidance on what to do with patients who don't want treatment. They just want treatment of their withdrawal symptoms. So what the 72-hour rule means is you can't give more than 1 day's medication at a time. So this doesn't have to be inpatient, although every program I've ever worked with, we have done it as an inpatient, simply by nature of these women are pregnant and we just like to keep a closer eye on them. This treatment may not be carried out for more than 72 hours, and the 72-hour period cannot be renewed or extended. So you can't have a patient that you treat, you get her set up to go to the methadone clinic, oops, she oversleeps, she doesn't go to the clinic, she shows up the next day in withdrawal, I want to start my 72 hours over again. Federal law does not allow for that to happen. Now, what about if she had it in one pregnancy and then she comes back in another pregnancy? When I've talked to the Opioid Treatment Authority, which is sort of the state director for managing all of the opioid treatment programs, he said, well, this will be decided by case law, so kind of manage a patient as you see appropriate for their care, and then if it's a legal problem, you can figure it out later. I don't want to be case law. It's not part of my goal as a physician. So as far as I'm concerned, the 72-hour period is something we make clear to patients. I can really only offer you this once in your pregnancy. You're telling me you want to get to a treatment program. This is a step to help you there. But if you miss that appointment, I can't provide you with this medication. Again, I can give you medications to treat your withdrawal next time you come in, but I can't treat you with opioids to get you into that program. So this is what information you need to have when the patient walks in. So you want a visibly pregnant woman or a urine pregnancy test, urine drug screen. Where I was before, we did these witnessed, but certainly if you have the door open, the patient is just in a Johnny, she doesn't have anything with her, and the nurse is standing at the door, that's very reasonable. Do a good exam looking for track marks, so looking at arms, but not just arms. Sometimes you can see abscesses on their legs and their ankles. Patients will inject wherever they can find access to a vein. Make sure that they have prenatal labs, and especially don't forget to look for things like TB. There's a very high incidence of TB, HIV, and what's the most common infectious disease in substance use disorder pregnant patients? Hepatitis C. So up to 60% of these women will have been exposed to hepatitis C. Hepatitis C is a really great treatment, but it hasn't been tested in pregnancy yet. But still getting these women, identified during their pregnancy and getting them set up with GI is a very important first step. So in order to treat someone with the 72-hour rule, you need to demonstrate that they are actually dependent on opioids. And so you need to establish physical dependence to treat for withdrawal in an emergency setting. So the first thing that you want to do is use some sort of objective clinical scoring tool to identify if they're having withdrawal or not. How many of you have ever seen a woman who's withdrawing from opioids before? So about 60% of the room, I would say, raise their hands. So when you haven't seen somebody before, I think it's kind of important to look through the scoring and understand what sorts of things you're going to be identifying women with. There are two scoring systems that are currently used in pregnancy, the Clinical Opioid Withdrawal Score, or COWS, and the Clinical Institute of Narcotic Assessment. Most of the research that's done in pregnancy has used COWS. I don't know if that's because most of the research is done in dairy areas, so we just kind of like that name, the COWS scoring, because I was in Vermont, they had a lot of cows, and they have a lot of cows here, and so we all use this. It's also a lot easier to use because the CINA scoring, there's the scoring, and then it's out of 31, but it doesn't separate it by mild, moderate, or severe withdrawal. You take how many points they have and divide it by 31 and get a percentage, and it's just less objective when you're relaying the information to another provider, especially over the phone. So I will make sure you get sent this because this is the scoring that you're going to go over with the patient in the room. So you may have to make sure that it's a well-lit room because if they turn the lights down, what happens? Their pupils get bigger, and that's one of the things you score women for. And women know this. They'll turn the lights really low. Oh, no, I have a headache. Nope, I have to have the lights on. I'm going to give you 5 minutes with the lights on, 5 minutes resting, and then we're going to go over this scoring sheet. And there are objective things that you can see on the patient, or you can check their vital signs, and there are subjective things that the patients will report to you. So resting pulse rate, sweating, you can see if they're sweating or not, if they're unable to sit still, you look at their pupil size in normal lights, you look for bone and joint aches, so again, that's going to be something that's subjective. Runny nose or tearing, they'll sit there the whole time, rubbing their eyes, and just women see, do you have allergies? So that's another objective one. GI upset, you often can't see unless they're having significant diarrhea while you're there. Tremor, so you just have them hold out their hands like this, close their eyes, and look for a tremor. Yawning, anxiety or irritability, and looking at their arms, when they're holding out their arms to look for tremor, look at their arms to see if they have any goose flesh. And a lot of this you can do even while you're getting the history, you can kind of be paying attention. And so you might say, okay, I can get the restlessness, I can get the sweating, I can get runny nose, yawning, probably 50% of these things just during your interview. And then, okay, I have to take your pulse, I have to look at your pupils, stick your arms out, I'll look for tremor, and I'll look for goose flesh, and you can get essentially everything that you need just during that time. So you add up the score, and patients need at least a 5 to start on treatment. I would argue for buprenorphine, I like them to be closer to 10 to 12 because I don't want them to be miserable, but I really don't want them to have precipitated withdrawal. And if you've seen precipitated withdrawal once, you will never, ever want a patient to have that, whether it's from giving them buprenorphine when they still had other opioids on board, or if somebody gives them a partial opioid, like Stadol or Nubain when they come in labor and nobody knew that they were dependent on opioids. So a little bit worse withdrawal to start. I would say aim for a goal of 10 to 12 for these inpatients that we're going to have. So you need to score a patient when she comes in, 2 hours after the buprenorphine, because that's when you're going to see the effect of if it's working. If the nurse comes out to you and says, this patient just keeps falling asleep, I think there's something going on. If she just went out to have a cigarette and all of a sudden she comes back and she's slurring her words, there are lots of different times when you want to score them to see what's going on. And if they went out to have a cigarette and their score was 10 and now all of a sudden it's 0, there may be something else going on. So there are a lot of times, and I would encourage all of you to try and practice the scoring if you can, and you can let the patient see the sheet, or you can say this is something we do with all of the patients that helps us judge how effective your treatment is. So these are some of the other questions, and again, some of these are uncomfortable to ask, but if you phrase it, and I think that by and large, when I ask patients these questions, they haven't been asked these questions before, and they really appreciate you wanting to know what else is going on in their life. Do they have any kind of employment right now, or do the other people they're living with have employment? What kind of family support do they have? Do they have a stable place to stay? Legal issues we talked about, asking about a history of psychiatric disorders. So 50% or more of these women will have some concomitant mental illness, depression, anxiety, PTSD. Some women will have chronic pain syndrome. That may be why they started on opioids to begin with. Do they have a reliable phone? Can they get to the clinic for their medications? Do you need to arrange some sort of transport? Have they or are they currently on benzodiazepines? That is the one medication that it is recommended you not give buprenorphine with, because although buprenorphine has a very low overdose risk, if a patient's on benzos, that risk is increased by over 10-fold. So finding out, even if they're not using them prescribed, asking about benzos, what's their motivation for treatment? Why now? A lot of women, it's the pregnancy, and that can be a very good thing for them to help them get into treatment. Do they agree to go to a counselor? If they say, I'm only doing the medication, I'm not doing anything else, you say, you know what, this is really a full spectrum recovery. Medication alone is not going to get you to where you need to be. Kind of like insulin alone is not going to get you to where you need to get with diabetes. If you're still eating Glamdol donuts, half a dozen every day, your diabetes is not going to be under control. So I give them those kind of analogies. This is a medical problem that needs more than one treatment. And what other history of abuse do they have? Now, you will have a lot of patients where they'll come in and say, yeah, I buy a lot of buprenorphine from my friends, or just, on the street or illicitly. But they're not buying the buprenorphine to get high. They're buying the buprenorphine to stop the withdrawal. And making that differentiation is very important. A large percentage of diverted buprenorphine is, my boyfriend's got buprenorphine. He has a treatment program, and he gives me half of his tablets or half of his film so that both of us have just mild withdrawal rather than neither of us having it. So kind of getting that information is important. And then acknowledging that we are treating patients, but patients have to be partners in the treatment program. So when they come in, finding out, do they have transportation? Do they have childcare? What's their work schedule? Are they going to be able to keep their scheduled appointments? When you start on methadone, you have to go every single day in the morning. When you start buprenorphine, you have to go at least once a week for your prescription. That would be either from me or from the community health center. And so can they do that? Are they going to treat the staff with respect? I need you. I know that if you miss an appointment or you get your prescription stolen or lose it, you need to be nice to my staff. Everybody here wants you to be healthy, but you need to be kind. And they need to be honest with us about relapse. If somebody uses while they're going up on their medication, that doesn't mean I'm going to kick them out of the program. It means we need to have a conversation about what happened. What can we do to prevent this from happening again? They need to be honest about diversion. And if they are caught selling their pills or giving them to somebody else, for me, that's a hard stop. I don't want to be contributing to some of the problems in this community. And that could be grounds for termination. So if somebody comes in 2 weeks in a row, their urine is negative for buprenorphine, that's a problem. And I say is, good news. Looks like you're not taking your medication. Looks like you don't need this medication for your treatment. So we're going to be able to stop that. And then they may tell you what's going on. But you kind of talk to them, or, I noticed that, you're calling in, you're calling in with missed prescriptions, or you're not making it. I'm going to need to have you come 3 times a week instead of weekly, because it doesn't look like you're safe to only come once a week. So you kind of up their responsibility, and they'll either engage in treatment or they will not engage for a while. And hopefully you say, I'm happy to help you at a later point. Always check the PDMP. How many of you are aware of what the PDMP is, or the PMP? So the PMP, 49 states have these. The only state that doesn't is Missouri. Little factoid. And they are prescription monitoring programs that if someone picks up a prescription for opioids, it is entered into this database. The problem in Minnesota is our residents don't have a DEA license, so you can't actually check the PMP. So you need to have us either delegate you to check for prescriptions or ask us to sign in. And probably ask us to sign in. You can get to it through the right through the Fairview system. It's very easy, or I can kind of show you how to do it. And when you're on my service, I'm happy to designate you to look up under me. It's a really nice program. You can look at different states as well. You can. I was not aware that you could have logins. Oh, yay. That makes things a lot simpler for... So how many of you have them? Oh, that's fantastic. That makes me so happy. Yay. That'll be great for my lecture on responsible opioid prescribing in August for you guys, because I thought that was going to be a problem. So first and second years, talk to everyone to raise their hands and get that, because I was providing misinformation. I didn't think that you guys could get those. So you could also access surrounding states. So we had a patient who was getting all of her prescriptions from a pain doctor at Twin City Pain and driving to Wisconsin to get them filled. So when you look at the Minnesota PMP, she had nothing. When I looked at Wisconsin, she had a whole bunch, like 4 or 5 times what you needed to do. So just think about those things, and the Minnesota one allows you to access other states. I also tell patients, if you have benzos in your urine, that's going to be a deal breaker. And I'm going to say, I'm sorry, I can't partner with you. Now, if they admit to a benzo problem and we need to wean them off, that's a whole nother issue. But if they continue to use benzodiazepines and are unwilling to go through a taper, that also may be a reason to discharge them from care. So, buprenorphine induction. Buprenorphine comes in tablets. It comes in a film. If any of you have kids and you've used those kind of dissolvable cold medication, it's just this clear film. They either put that under their tongue or on their tongue. The tablets, they have to tuck into their tongue. Apparently, they taste really gross, kind of like Cytotec, I've been told. But they have to stick them buccally and wait for them to dissolve. And if they need a whole bunch, if they're on 16 milligrams and they're 2 milligram tabs, they have to do 4 and then maybe put 4 on the other side or spread them out. But it's not an easy medication to take on a daily basis. But when these patients come in, it does not work if it's swallowed. You ideally would have either the nurse or sitter, somebody kind of just sit in the room with them. Mostly because I want to make sure they're not putting tablets under their pillow or sending a friend in to get them. Desperate people will do desperate things. Minimize visitors during the treatment start. So I just say to them, once we start the medication during the period when you're getting the pills, I'm not going to be able to allow you to have visitors. And that's because we really want to be able to watch you and get an accurate assessment of how much of this medication you're going to need when you go home. I want to make sure you're on the right dose. So when you get the pills, while we're waiting for them to dissolve, you can't really have any visitors. And then they're going to need repeat scoring throughout the course of their 72-day period. So patient comes in, you score her, yep, her score is a 12. Pretty much anybody can be started on 4 milligrams. When you read the literature, it says 2 to 4, but I don't want to say never, but you're highly unlikely if someone's demonstrating withdrawal symptoms to cause someone to have overdose. Number one, because buprenorphine, the partial antagonist effect, it's very difficult to overdose, and 4 milligrams remains a relatively low dose. So you give them 4 milligrams, wait 2 hours, score them again. Their score should go down. If their score is the same or higher, and it doesn't seem like it's precipitated withdrawal, you can give them an additional 2 to 4 milligrams until their symptoms go away. So if somebody was a 12, I gave them 4 milligrams, now they're a 10, I would probably give them another 2 to 4. And this is more of a trial and error kind of thing, depending really on how uncomfortable they are. You're not going to overdose somebody on 8 milligrams if they still have withdrawal symptoms after 4. So the max you're going to give somebody is 8 milligrams in a day. Now that may not be enough. Typical dose that patients are stable on that works well is 16 milligrams. The maximum dose you can give somebody is 32, although 16 is kind of where people sit. Most of my patients are somewhere between 8 and 16. The max you'll give them in the first day is 8, which means they may still have withdrawal symptoms that you're going to need to treat. The next day you say, okay, I gave her 12 milligrams. I'm going to give her 12 milligrams in the morning. I'm going to wait 2 hours, have her scored again, and then you kind of do the same thing. And you can go up to an additional 8 milligrams for a total of 16 on the second day. On day 3, you take that total, you give that in the morning, and then you start talking about, are they stable for discharge? Do I have a plan to get them home? So the way it works here is the discharge pharmacy will do all of the pre-authorizations. They do not have significant difficulty getting pre-authorization either from Minnesota Medicaid or most of the private insurance. But the earlier you tell them a patient's here, the better. So if a patient gets admitted, call them that day and say, I'm starting a patient on buprenorphine in the clinic. She's going to be leaving with a prescription from Cresta Jones. Can you start getting pre-authorization? You can give them my number, all of that. We want to talk about safety with medications. So when they go home, they will get a week prescription from me or the 2 other providers in our practice who've applied for their waivers. And then they will go to the Coop clinic after that. But the most we will give them, so they will get a week to get that appointment. They will need a prescription for Narcan because there's always a risk of overdose. And I would argue that every patient who acknowledges opioid use should have a Narcan prescription, and they will not get any refills. They should have a lockbox. They should limit who knows about their medication. So precipitated withdrawal. So I don't want to scare people with this, but this is really why I've had patients come in and they are clearly comfortable. No, it's been a day since I used heroin. We're going to have to watch you for another day, and that's not going to count in your 72 hours, but you have to be withdrawing because this is just acute worsening of their withdrawal syndrome. And so this is kind of important to know when patients come in. It has to be at least 24 hours for essentially everything except methadone. If they've been using methadone, it needs to be 48 hours. So at least 24 hours and significant withdrawal symptoms. And if you're not sure, just call me. So this gets worse after buprenorphine. You cannot make it go away. It doesn't matter if you give them a fentanyl drip or anything. The affinity for the receptors is so high with buprenorphine, it's not going to make a difference. So all you can do is give them supportive treatment. So using all of the withdrawal medications, and this is why we talk to them. This is why it's so important. I don't want you to be sick at home. And sometimes we'll give them, talk to them about, I'll give you a prescription for 1 night of trazodone while you're waiting, or I'll give you, recommend Benadryl, anything that'll help you sort of sleep through the withdrawal so you can come in the morning and start treatment. So that's the buprenorphine start. Any questions on that? You will all be getting to a template H&P that I think Tia and Melinda already have. And I think you got the edited one today as well that kind of talks through this admission. Hopefully we'll get it into a dot phrase or a smart text that you will just pull that up automatically when these patients come in as well. So methadone's different. You need an opioid treatment program. These are federally regulated. I don't have the ability to prescribe this other than for the 72 hours, the same as all of you. There's no risk of precipitated withdrawal. So if women have a withdrawal score of 4, you can start them on methadone. In fact, they don't need a withdrawal score of anything, but we like to see some withdrawal to prove that they're physically dependent before we start them in a program. It has a very long half-life. And I say this because the highest risk of overdose when you start methadone treatment is in the first week. It stacks. So the first day they could be on 30 milligrams and feel terrible. The second day they feel sort of terrible. And the third day they could overdose and stop breathing because that it just takes that long for it to work and has a very long half-life. So for that reason, the most you would ever be giving any patient who comes in who says, I want to go into a methadone program is 30 milligrams, and you would give them that for 3 days. They would then go into the methadone program, which we would help arrange with discharge planning, with our social work, with sometimes just some phone calls from us. Many of these women will be on 150 to 200 milligrams by the end of their pregnancy, but this is all we can give them when they come in for 72 hours. So I usually start women on 20, check them again after 2 to 4 hours. If they still have severe symptoms or symptoms are going up, add an additional 10. And then I say, that's all I can give you, but we can max out some of the withdrawal medications to assist you while we're getting you into a program. Methadone has, again, significant overdose risk, so we need to watch women for sedation. We need to discuss with them these are your obligations. I'm sending you to a clinic you're going to have to go to every single day for a good chunk of your pregnancy, and what does that look like for your life? You need to coordinate discharge. So if we have a woman who comes in on a Thursday and we treat her until Saturday, and the clinic's only open Monday through Saturday morning, which is how the clinics work, everybody gets a take-home dose for Sunday, you're going to send her out and she can't get in until Monday. So understanding if we're going to admit a woman and start her on methadone, if we have the luxury of picking when, we need to coordinate it so discharge is on a Monday through Friday so she can go to the clinic the next day. Most of the clinics will work with us on that. And then reliable transportation. So this is a list of the medications, and I won't go into the details of these a lot, but on the information that you're going to get for this sort of template for admission, all of the dosing is on there for these medications. Most of the women that come in are going to need some level of some of these just to get relatively comfortable. So just briefly, some of the other things that we need to think about. And this is, I think, a really striking statistic is 16% of women in general who are pregnant will be identified as suffering from tobacco use disorder or using cigarettes or vaping or what have you when they come in pregnancy. Up to 90% of women on medication-assisted therapy will identify as smokers. And almost 50% of women who are not struggling with opioid use disorder will quit on their own cold turkey in pregnancy, and less than 5% of women in MAT, which is medication-assisted therapy, will do the same. So this is a very real problem, but I also acknowledge that if I'm asking you to completely rearrange your life, to go to the methadone clinic every day, there's only so many things you can fix in a day. And we even think about it, well, I'm going to get more organized, and I'm going to exercise every day, and I'm only going to eat this paleo food. You can't do all those things at one time and be a resident and be on night float. So it's the same for these patients. Let's just work on your opioids, and we will address getting you to quit tobacco later. But let's talk about trying to get you to cut down. So when do you smoke? Could you smoke half a cigarette and then break it in half and just cut down that way? Because there is good data that if women can get down from a pack a day to under a half a pack, their babies will grow better, and their baby's neonatal withdrawal will be less severe and shorter. So there are very good reasons, not just for their personal health, but also for their baby, to get them to cut down. Incentive-based treatment is very effective. We don't have a program in this state, but there are a lot of other programs where women get incentives for trying to cut down and eventually quitting. So thinking about that, or saying, women, if you cut down from 2 packs a day to 1 pack a day, can you use that money and reward yourself with X, Y, or Z? But just sort of thinking about those kind of things. And often just us saying, I get it. Quitting is hard. Let's talk about how you can cut down. If women feel like you understand, they're going to be more honest about this. So again, I talked a little bit about the high rate of depression, anxiety, PTSD. I would argue that every one of these women should at least be offered a perinatal psychology or psychiatry consultation while they're in-house, because there may be a lot that comes out once they start on buprenorphine that they were masking with their opioids and trying to treat. We know that women that have mental illness that's not adequately treated have an increased risk of preterm birth, increased risk of fetal growth restriction, However, we have to balance that with the increased severity and duration of NAS if women are on antidepressants, if women are on gabapentin. And again, I would argue that my priority is the whole woman, and I will accept a couple extra days of NAS if I have a patient who is engaged in treatment, who's not suicidal, who has a lower risk of postpartum depression. But you do have to sometimes have that conversation as well. Team communication is the hardest part of treating women with opioid use disorder because there is a special federal regulation on the disclosure and sharing of information related to substance use disorder. Whether this is appropriate or not is a whole nother argument. This takes substance use and makes it a special sort of shameful thing rather than saying this is a medical condition and it should be shared with all the rest of your records. But this is important because it's a special informed consent. You have to specifically say, I give Cresta Jones permission to talk to my methadone provider about my substance use disorder or all of my treatment, and they have to specify, and then they can revoke this consent at any time. So it's important to have the patient sign consent at admission. Hey, I know you're going to go back to the Kook for your buprenorphine and see Dr. Kelly. We're going to sign this consent today so I can get this arranged starting the first time that you're admitted. But it's important to be aware of that. The same if you have patients coming into your clinic who go to a methadone program, have them sign a consent as well. Ask about social support. So many women are embarrassed to say they have trouble getting food. They don't have any place to stay. They have nobody to watch their kids when they come to the visits. And yes, it is extremely annoying for all of us when someone brings their 2-year-old who's running all over and spilling food in our exam room, but sometimes women have no other choice. And so we have to agree to be more understanding about them showing up a little bit late and bringing their kids and having somebody else there because that's sometimes the only way that we can get them engaged in care. And offer social work to them early. So patients come in on labor and delivery. The most important thing is that they stay on their medication. So a woman comes into your clinic and says, I'm getting buprenorphine from the NAC. Okay, how much do you take every day? Women will often say, well, it's different every day. Sometimes I take 6, sometimes I take an extra 2. It's not the same time every day. That's great. The inpatient pharmacist at Fairview is not going to dose it to you that way. So you need to figure out what's a dosage you can get while you're in the hospital. What times of day could you get it that you're not going to have withdrawal? And if you're prescribed 8 a day, why don't we give you 8 a day and why don't you pick the times? And then I write in the chart, patient on 8 milligrams takes at 8 a.m. 4 milligrams and 6 p.m. 4 milligrams. If you write it in the chart and it's documented in the record, it's a lot easier to get the pharmacy to dispense it. This is particularly important for methadone. Because of that 30 milligram overdose risk with methadone starts, the pharmacy, if they can't validate a patient's dose, will only give them 30 milligrams. So imagine you have a patient, it's a Sunday afternoon, she's on 200 milligrams of methadone a day, she comes in for induction, and you can only give her 30 milligrams. It's not going to be pleasant, believe me. So if you have documented in the chart, confirmed patient takes 200 milligrams a day, you call the pharmacy and say, I know you only like to give 30, her clinic's closed, it's Sunday afternoon, but we have this documented in the record. Quite often they will agree and then say, okay, fine, but Monday morning I have to call the clinic and confirm. But make sure that you talk to them about that ahead of time and document it. Early epidurals are important. Patients who are on chronic opioids have significantly reduced pain tolerance. If they have a cesarean section, engage in alternative treatments to help decrease the risk of extra opioids needed. Now, this doesn't mean they're not going to get their methadone or buprenorphine. That won't treat any of their pain. That's going to treat their withdrawal and their opioid use disorder. But if we can minimize additional opioids for the patients, it's going to help them a lot on their long-term journey. So TAP blocks, scheduled non-opioids. So if you do Tylenol, then 3 hours ibuprofen, 3 hours Tylenol, 3 hours ibuprofen, round the clock, that has been shown to have a significant improvement. IV Tylenol has also been helpful for patients who are struggling after a C-section. It's expensive, but if it's something that we can get even for one dose, it can be very helpful, especially after a C-section. Leslie Renfro, I'm sure some of you are familiar with her. She's one of our anesthesiologists, is very committed to working with this population and doing what's called enhanced recovery, which is really focusing on proactive treatment with non-opioids from the get-go to help reduce the amount of medications that all our patients are getting, not just patients who have opioid use disorder. If patients are stable in recovery, we should encourage breastfeeding. There's minimal transfer of medications. Moms who breastfeed, the skin to skin, the rooming in, all of those things reduce the duration and severity of NAS. This is supported by virtually every organization that's involved in maternal or child health care. The only contraindications are ongoing illicit drug use, active HIV infection, and with hepatitis C, if they have bleeding nipples, they should pump and dump, but once the cracks in their nipples have healed, they can continue to breastfeed. So postpartum, and this is not just for opioid patients in OUD, but also any patient, I would say, the most anyone needs after a C-section for C-section pain is 7 days. And yes, if you're on a buprenorphine program, you're going to need more medication, but you're not going to need it for longer. So I look at the 3 to 4 days they're in the hospital. The first day of discharge, they get that same dose. The second day, they get a smaller dose. The third day, they get a smaller dose. And that's all they should need at home. I say, if you need more than that, we need to figure out what's going on. You need to come back to the hospital. Is it a pain to have them call me on call on a Saturday at 1 o'clock in the morning because they're in pain? Yeah, it is. But it's the right thing to do to minimize the amount of women who relapse and just to minimize opioid overuse in general. If you prescribe more than 3 days, you should probably be checking the PDMP or the PMP before discharge. But talking to them about, you're going to get 3 days, but it's not going to be 3 days of the same dose and then you're done. It's 3 days after you go home and it's gradually declining doses. Methadone often needs to be decreased after a patient delivers, but that should be the responsibility of the prescriber. We should give them the same dose for those 3 or 4 days they're in the hospital, unless they're oversedated, in which case we may need to contact addiction medicine here or just talk about decreasing them by 5 or 10%. Make sure you have the contact information for their prescriber before they're admitted to the hospital, if you see them before they come in to deliver, so that you can call them as soon as the patient delivers to schedule their next visit with the treatment program. I have all these women come back after 1 week for depression screening. What's going on? Do you feel like you're at risk of relapse? What kind of support do you have? How are you doing with your baby being in the hospital? And LARCs can be very effective for this patient population and are often widely accepted. So make sure that you've talked to them about that. If you can't do immediates, which hopefully we'll be able to do soon for everybody, talk about having them come back to have that placed at their postpartum visit. So I do make sure that moms are aware of neonatal abstinence, knowing that their baby's going to stay in the hospital for at least 5 days. Average length of stay with neonatal abstinence, 14 to 17 days in most of the hospitals in Minnesota. So say your baby's going to be in the hospital longer than you. Do you want to talk to the pediatricians before you come in to deliver? Do you want to tour the NICU? Does somebody in your family knows what's going on? If not, do you have a good story for why you posted your delivery on Facebook and now it's 2 weeks later and your baby's still in the hospital and you delivered on your due date? That can be a big trigger for relapse for patients. If all of a sudden they run into Sally Smith from their high school class and she's like, why is your baby still in the hospital? And they haven't sort of thought about what they want to tell everybody. So I just say, have you thought about what you're going to tell your family? What are you going to tell your friends? You need to prepare for a baby that's going to be in the hospital longer. I often tell them the baby's jaundice and can't get out. Tell them it's struggling to feed. Tell them it can't gain weight. And not that I want people to lie, but I also don't want to put them in a situation where they relapse because they are ashamed or embarrassed and don't want to tell people what's going on in their life. So this is obviously a big issue. It's only continuing to increase, even as we rein in prescribing. Fentanyl is becoming more and more of a problem in this community. Appropriate treatment starts with screening, and I didn't talk a lot about screening today, but certainly we can talk about that in the future, just about what does the verbiage look like, how do we talk to them. Every woman should be screened for substance risk at their first prenatal visit, full stop. And whether that is using something like, within the past year, have you used any illicit substances? Within the past year, have you used any alcohol? Do your family have any problems? Does your partner have any problems? There's a very simple set of questions. But making sure that we are comfortable, and we ask everybody about this, just helps me take good care of you. Understanding the 72-hour rule, and making sure you ask about the other issues that will keep women healthy. We're really looking at the long game with these women, not just keeping them pregnant as a vessel for a healthy baby, but how can we help this woman have, a good life course. And then I just have 2 slides on something that's really important for all of us that I don't think I really paid attention to until this year, which is advocacy with this. And you say, well, you haven't really talked about that. No, I haven't, but I just want to give a little plug to all of you, no matter what your political leanings or your beliefs are, about making sure that you speak up. And change is not going to be made at the federal level, especially for this type of patient population. It needs to be made at a local and a state level with pilot grants for programs and funding and decreasing criminalization in pregnancy. Physicians rarely utilize their power, and I didn't realize it till this spring. And now I email my legislators. It takes me 5 seconds once a week. And if you call them, eventually they will look to you for stories and for guidance. And writing letters doesn't mean you have to learn to use a piece of paper. Again, you just click on the link for Eric Paulson, and I write to him every single week about this issue. And you can get involved with many organizations in the state of Minnesota who are active with all of the issues that are important to us. So I would encourage you to do that. And what are all of the residents doing when they're on my service on election day? You're going to vote. So every single person makes a difference. Every single raindrop has to contribute together to make a flood. Every one of you is important, and you have the right to vote in every election and to have coverage from work to go. So just make sure you know. And if you haven't registered to vote or you don't know you're voting, come to me and I will help you do it. Because this is very, very, no matter who you vote for or what you believe, everybody needs to be represented. And so that's my little soapbox. And I'll answer any questions that you guys have. I think something else too, if you're in clinic or you are at a different hospital and you're like, I don't know the answer to this question, you guys can always text me or call or email me. I'm happy to talk through this stuff with you because I think it's important, even if the patients aren't at this center, that they're being treated with the right care.
First, I have a question. The confidentiality of alcohol and drug use. Where can we get that from? Do you have to only get it on the website?
So that's a question I have on my little list of things to do for you guys, because every place has a different, so when I worked at my former job, I called all the methadone clinics and all of the providers, and so I had copies of the ones from the methadone clinic, and I would have the patient sign those, and I would fax them back. That said we could talk both ways. I don't know what the Fairview or UMP form is. I'm assuming we have a separate form somewhere. I've emailed Denise and Ellen to ask them, and if I get one or if we find one, if we could send it out to everybody in the department. Okay. Okay. Right. And if we need to generate a separate one that makes it easy, I'm happy to if you just type that in, they have templates online for what you can do. It's pretty simple. All right. Well, thank you guys. Oh, Becky has some. Oh, thank you. And then we'll send that out to everybody too, because it's essentially the entire H&P is already done. Just the plan is what you'll need to do. All right. Thanks, you guys. On the slides to share it. I just didn't know if I was going to get through it.
I took my run club to the voting polls. All my residents. Yes, I'm just calling.
We could take like a 5-minute break because I can stop the taping and start it on the next person.
Hey Cody, it's Becky. If you want to stop recording, and then hit play or record again.
You have been disconnected from the meeting.